Welcome to the presentation on the Halo brace titled Halo to Save a Life. My name is Bill Carlton. I'm a certified orthotist. I work at a level 1 trauma center in Dallas, Texas, where we see a number of trauma victims. And we recently had a couple of patients, both pediatric and adult, who accentuated the value of the Halo. If you would look at the next slide, you will see that the concept of a halo is that it is used in scenarios, obviously, where a person's condition is serious enough to require the risks that are associated with the invasive procedure. It doesn't take too much intelligence to look at a halo and realize it's a serious brace. Many of you who have put them on or been involved with them recognize there are issues that can develop, and we'll speak to those in a little bit. But I thought as we considered the reality that halos, as well as many other devices, those of you who are prosthetists and orthotists recognize that just about everything you do has a real opportunity to save someone's life, or at least improve their life, make a difference in their life. And it's worthwhile to consider the seriousness of that and the value that we offer people as we try to do what we do. Injuries that are appropriate for a halo are generally appreciated following a traumatic scenario, a car accident, a fall from height, with a radiologic appreciation of the injury. Various radiologic instruments are used these days. The X-ray, the CT scan, the MRI seem to be the most popular three to appreciate the kind of cervical spine injuries that halos are constantly being used for. Neurosurgeons and orthopedic surgeons generally are the ones who are involved in caring for the spine and spine injury, and they are looking for a number of potential areas of problem in the cervical spine, not just bony injuries, but ligamentous injuries as well as vascular injuries. All three of these types of injuries can be appreciated radiologically. This slide helps us recognize slices. The next slide here, visualization can be difficult, helps to point out the improvements that we've found recently, or I would say in the last 20 years, with the use of more advanced imaging techniques. On the left is a swimmer's view lateral X-ray trying to appreciate C7 on T1 jumped facets. You can recognize this was actually taken in the emergency room as we were trying with Gardner Wells tongs to reduce what we recognized was a dislocation appreciated on the right with a CT scan, where you can clearly see in the lower portion of the right slice of the CT scan the upper cervical spine dislocated anteriorly on T1, and perch. The facets have actually gone beyond being perched; they're actually destroyed. But as this was appreciated, an attempt was going to be made to try to reduce that with traction through the application of tongs screwed into the head. And as we were continuing to try to recognize if we had reduced the dislocation, CT scan is not possible in a speedy and available fashion for halo or traction. So we tried swimmer's view, and we're unable really to appreciate it very well. So this slide just helps us recognize that those of us who are called upon to help with cervical spine instability have to tip our hat to those who try to visualize and recognize things, even with advanced radiologic techniques. The next slide will be useful, I believe, for us to see that those who do try to appreciate injuries with X-rays and CT scans and MRIs try to do more than just get a big picture. Oftentimes they try to measure malalignments. On the right, it doesn't take much to recognize that in this case, a knee has a femoral component of a total knee replacement that has dislocated posteriorly on the tibia. And so perhaps in that particular scenario, seeing it is enough. But on the left is an X-ray of the ankle mortise, and the measurements are being made to determine if the ankle sprain and associated fractures have rendered the ankle mortise to be unstable and therefore might need a more significant type of surgical intervention. And the radiologist has techniques, as we could all imagine, with the computer to get down to millimeters of difference and space in areas where there should not be space. So this slide helps us to, I think, recognize that reality. And in a moment, we'll see how that plays into the cervical spine. So the next slide will be able to help us see that there are some measures for the particular condition that this talk is kind of centered around. I think most who recognize cervical spine injuries would see that this particular condition, atlanto-occipital dissociation, sometimes called internal decapitation, is a serious instability, as we'll discover a little later, often associated with traumatic events that are significant enough to result in death, oftentimes. But how to measure and appreciate atlanto-occipital dissociation has been a bailiwick for many years, determining distances between the occiput and the C1. So I've found a couple of journal articles. The one on the left, it mentions a number of different techniques where the radiologist and the neurosurgeon or orthopedic surgeon are applying measurement techniques to determine how far away is the head from the neck. And we're talking about millimeters making a difference. That would indicate, obviously, that the ligamentous structure that helps the head stay on the neck has been compromised. Neurosurgery article in the lower area improves on another technique that someone has to measure. My Google search on the right demonstrated the most common response to an inquiry about atlanto-occipital dissociation, and a scale produced the Glasgow Coma scale. This has nothing to do with an appreciation of the relationship of the head to the neck, but more often the reality that this injury is often associated with head injuries and other serious injuries. So this is just a touch base on radiologic measures. Now we can look at another concept that I think will be helpful, the indications for halo. Those who have done halos or been around halos recognize that there are a number of different things that would indicate the appropriate use of a halo. Instability of the cervical spine due to disruption or damage to 2 of the 3 columns of the cervical spine. This would be a bony injury. A burst fracture at C1, sometimes called a Jefferson's fracture. C2 fractures fall into either odontoid fractures or even one at the base of the odontoid called the Hangman's. And probably one of the more important realities of what's an indication for halo is that there are people there who are willing to do it. And I would be happy to recognize with many of you that there are a lot of hesitant clinicians to use halos these days. Surgical techniques have improved some. As I've spoken with some of the halo sales reps, they recognize that their volume in sales has gone down significantly over the last few years. And so the residents and orthopedic and neurosurgery docs that I'm associated with oftentimes are very hesitant to try to talk a patient into having something screwed into their head. And we can all imagine that's a challenge. So here's a thought about halos. We probably are familiar with these things. Let's look at one more thing about the halo on the next slide, and it might be useful. What are the advantages of a halo? Why would we even do this to somebody? Why would we screw something into somebody's head? Those of us that are orthotists are accustomed to putting things on patients' bodies, putting it on snugly, firmly, but sharp, pointy instruments that dig into skin and bone usually are not thought of as our components of choice. And the advantage of the halo is that it offers immediate and early mobilization. That is that the patient's injury area, the cervical spine, can be immobilized rigidly while allowing the patient to be mobile and move around. And it offers some comfort as opposed to perhaps other devices. Curiously, if you've taken a halo off a patient and put them into a collar, they will begin to complain about the fact that it's under their chin. Surely that doesn't make them want to go back into the halo. But what is it that causes a halo to be really useful as opposed to surgical intervention? Surgical intervention usually results in fusion of one or more segments of the cervical spine, which means they have a loss of motion, loss of mobility. And although that has no application to the 2 cases I'm going to speak about today, it certainly has been a long-term advantage of the halo in treating most often C2 odontoid fractures, type 2 odontoid fractures. Advantages of the halo. Next slide will help us recognize surely that we know there are disadvantages. As I spoke to earlier, it requires a knowledgeable team, a minimum of 2 people to apply it. And if you're going to do a proper application of the vest component of the halo, you ought to have 3 people. All of the people involved should be somewhat knowledgeable about how the halo is properly applied. We'll go over this in a little bit, but there's a little anxiety sometimes on the part of the fitter, the orthotist, and the surgeon to do it at all. The patient is usually awake. That doesn't present the most pleasant experience. Long-term use of a halo does limit arm motion. I'll mention something about that in a moment. It's almost humorous. And it is an invasive procedure with an infection risk. Maybe some of us have put on orthotic devices that have rubbed a sore or ulcer on a patient's led to infection. Certainly not what we intended. It is going to be an obvious outcome with a halo that they're going to have an invasive space, 4 spots at the least, that are open sore spots, wounds that could be infected. And reality about the halo is that the vest component of the halo is not as well affixed to the trunk as the ring is to the head. The head component is obviously screwed into the skull. The vest component is only fitted snugly around the chest. I think that does a pretty good job of helping us recognize the disadvantages of the halo. Let's move on to how we would put a halo on. Just a reminder, if any of those of you who have done one in the past and feel a little uncomfortable, proper ring placement is the key to halo application. It's probably what the orthotist is most useful for, to be attentive to that component, making sure the ring is where it belongs. It's tempting to place these pins. Usually there's 4 pins at the very least, with children more pins even as you go down in the amount of torque that's being applied. But 4-point fixation, a box-like arrangement, provides the best fixation. And there's a temptation sometimes when applying the ring to put the pins that are posterior just above the ear, because it's hard to get back behind the back of the head. And I certainly, we'd all know that's not a good idea. So that's one part of the proper ring placement. We'll go on to other thoughts here in a moment. The next slide, lateral placement. You want the ring to be, the guy who taught me said that it should be at the equator of the skull and yet not touch the ears. That would be usually just above the eyebrow ridge, just above the ear, trying to not walk up to the top of the head. There's often a temptation, particularly with females, to put the ring up high enough that it's in the hairline, and then it never shows the little scars from the pins at a later date. It's not always a good idea. I've seen halo rings migrate off the top of the head, and that's certainly not the outcome we're looking for. So that's lateral ring placement. I think we've got another slide that talks about pins. Actually, avoid critical structures. It's hard to know some of these things. One that usually gets the most mileage is to avoid the anterior nervous system that's just in the middle of the eyebrow area. So the pins are a little lateral on the brow ridge, but there are sinuses, and I would say if you do enough halos, there's going to be a moment when you put a pin someplace where you wished you wouldn't have put it. Determining that there's not a fracture in the skull is useful. Finding out if there is a scalp wound that we have to avoid putting the pin through. I put pins through scalp wounds and had them be soupy and not get infected. And yet others, particularly the surgeon's choice here, is to avoid that and put the pin a little differently oriented than where we might have liked it. So pin placement is important, and certainly as an orthotist, if you're involved, you're going to talk about the anterior pins, the safe zone, 1 centimeter proximal to the eyebrow or orbital rim, and you're going to go about 2/3 the lateral, 2/3 above the eye. Follow the equator of the skull. I think we've covered these things pretty well. One thing we probably who've put halos on recognize, it's not valuable to put the pins anteriorly first and then come later to do the posterior pins. All that tends to do is walk the ring forward on the forehead, so you don't have good placement of it. You put the pins in at least one opposite of the other, contralateral. If you're going to do an anterior right one, you should do a posterior left one, and do them kind of in sequence to keep the ring placed properly. We'll look at the next slide and recognize the posterior pin placement should be in that parietal area of the skull and below the equator, or at the equator if at all possible, and this 4-point fixation. I think that pretty well covers the pin placement concepts. Tightening the pins is important. You're going through soft tissue into bone. You never want to see a CT scan that has a slice showing the pin inside the skull. If you've done enough halos, unfortunately, you may have seen that. The CT scan slice on the right shows an anteriorly placed ring. I talked earlier about putting the pins in anteriorly too tightly and not putting the posterior pins in early, and that allows the ring, forces the ring to walk forward. So here we actually have the posterior edge of the ring into the scalp. This required replacement of the ring so that the patient didn't get skin breakdown on that scalp. You're looking to penetrate only the outer table of the skull, and most of the time that's where the pin will stop if you torque at the right amount of torque. Next slide, we'll discuss putting it on. The technique is sometimes we use a tray to hold the head out over the edge of a gurney or bed. Recently, some of us have been rolling patients into the vest first, laying them back on the gurney or bed, and putting a package of 4x4s or some folded towel behind the head while the ring is being placed. The shorter torque drivers that are breakaways don't require as much room posteriorly for the pins to be torqued properly, but this is a technique you're seeing here that has been used in the past. Next slide shows another concept with halo application. Certainly halo application is not done independently by the orthotist. It is an invasive procedure. The closest I've ever come to being the main person in the room is if the anesthesiologist and a resident are there, but I'm never putting the halo on by myself, nor do I recommend anybody else listening to this think of themselves as an orthotist putting their halo on their patient without the doc being there. There is anesthesia involved, even if it's a local, and it helps desensitize the pin area. If you put halos on, you know it still doesn't take away the pain, the force, and the pressure that the patient feels, but we try to move through this quickly. Okay, so halo application involves tightening pins in a logical fashion, and it involves the pins squeezing the head. You're going to get some response from the patient when you put it on, and you need to be willing to have a chatterbox going or distraction techniques. Certainly patients can benefit from sedation. Children oftentimes, if not always, are done in the OR under general anesthesia, but there's pressure, no doubt about it. Next slide will show us that there's a concept of traction. You can put halos on and have the head being pulled to try to realign things. In the case that we're talking about, atlano-occipital dissociation, the doctors that I work with make it very clear there should never be traction with AOD. AOD is actually an indication that a traction force was applied to the head during the accident, and we definitely are not trying to, if the person survived, we're definitely not doing traction. Next slide will show us the application of a cast with the halo. Don't know that many of us do that anymore. I just want to throw this in to show my mentor, Mel Stills, there on the right, in the same kind of cast room at the Parkland Hospital where I work, that has been going for about 40 years now. And Mel liked to put casts on people that had some severe kyphus and even under traction. Next slide, we'll start getting into the reality of our cases. Hey, this is our halo system we use. We use the PMT. There are others on the market. I think maybe there are 3 manufacturers now who still make and sell halos, but it involves recognizing proper alignment and the proper method of putting it on. And Texas life can be violent, maybe in other states as well. We like guns, we like knives, and so unfortunately, we see injuries that are involved with that level of violence. The next case, the next slide will show one of our cases, and that is a child who was not involved with violence, but it was involved with a violent moment during an MVC, 18-month-old cervical distraction. In terms of appreciating the problem radiologically, an infant has different measures on how to determine if the head is displaced from the neck. What was noticed on the MRI was there was blood in the space where there should be no blood, in that area where they would measure that there's too much space between head and neck. This led them to recognize there was some disruption. And so, what is it that the halo is being asked to do? And this is where the halo saves the life, I think. And that is, we are being asked to stabilize that person's C-spine to avoid in-hospital incidents that could lead to paralysis or death if that didn't take place in the field. So you or I show up to the ER somehow or another. Amazingly, our child, our 18-month, has survived an event that almost dislodged their head from their neck, and fix it surgically. We're holding things in place, and that is one of the particular values of the halo brace. Ligamentous injury. This child had no spinal cord injury. The second case study is almost the same. This patient's still in house as an adult, no spinal cord injury, and we had to wait 2 weeks before his hematoma and his neck resolved before surgery. He stayed in the halo for 2 weeks. He was intubated, and he wanted to write us notes. His arms were a little bit limited because of the halo. Finally, we got him a note, and he wanted to write a note that he really didn't like hospitals and he wanted to go home. So here we are, saving a life when the person really doesn't even recognize the seriousness of their injury. So I would suggest to you that halos have an opportunity to be helpful. If you have some around the shop, if you have access to them, you work with the hospital, you might just let them know you're available to help them get a halo on a patient in some of these scenarios. I really appreciate the opportunity to speak with you, and hope that in the future you might make use of the halo. Some literature review. The chairman of our orthopedic department a number of years ago did some morgue studies and determined 100 5 minutes. Yeah, 100 accident victims who died in the course of their accident. He did cadaver studies. 24 of them had C-spine injuries. 20 had C1C occiput injuries. And in this case, these were people who died of the car accident, and their head in the course of that violent moment came off almost. Recently, a San Antonio group of surgeons, UT San Antonio, survival rate they found was to be better. And that's kind of what I'm suggesting, is that you may see some AOD patients. Dale Earnhardt's well known as a guy who died from internal decapitation in a car accident. It's possible somebody like that might show up in your hospital that you might be associated with, and being vigilant and available to help will be useful. Okay, well, I think that's good. It's always useful to be part of the team, as all this slide seems to indicate. In our hospital, the orthotics area even has a little identity, and we try to be around and available to be involved with all kinds of services. Thank you for your time, and I hope you have a good afternoon.